session is about, first of all, needs for work on HIV, AIDS, and malaria, and then after the coffee break on public policy. We have 5 speakers. The first of them is Brian Williams.
Thank you very much indeed, Chris, and it's very good to be here. I really appreciate the excellent organization and what so far has been a really very good meeting indeed. I'm going to talk a little bit about AIDS and how we might end it, but really what I'm concerned about is the way in which we relate the science that we do to the practice that ensues. I mean, there's no doubt that in order to change the world, we really have to understand it first, but the problem is that understanding it doesn't necessarily mean that we're going to be able to change it. I was particularly struck at Professor Kortner's lecture at the dinner on Wednesday when he pointed out that after all the work had been done on variolation and vaccination and inoculation, what actually made the difference wasn't all the science that had been done, but the fact that Louis XV died of smallpox. And only when that happened did people all suddenly decide that they need to get vaccinated. So the things which bring about change in public health are not always the things that we think they're going to be. So just to give you a cautionary tale, a story which I think most of the people in the room probably know, but I always think it's worth repeating, is the story about Semmelweis, sorry, get a slide, too many slides in here. It's a story about Semmelweis who was working in a maternity ward and discovered and realized that about 7% of the women were dying in childbirth, which is a phenomenally high rate of mortality, especially if you're going to have 4 or 5 children. And there were 2 different wards, and what he knew was that the medical students in these wards were doing autopsies in another ward, and then they were coming in without washing their hands or anything and delivering babies. So what happened then, just I suppose by chance, is that after 1839, students no longer came into the red wards, the red maternity wards. Only midwives came into those wards, but the students still came into the blue wards, and what he saw was that the maternal mortality in the wards where the students were working was much higher than the maternal mortality wards in which they were not. So he must have thought about this for a long time and had a great insight and said, well, why don't we just get them to wash their hands, a nice simple procedure. And they all started washing their hands, and all the students, as soon as they started washing their hands, the mortality in the blue wards fell to the same level as the maternity, as the level in the red wards. So you say, well, this is a very nice and clear demonstration of the utility of washing your hands between doing autopsies and delivering babies. So what do? Well, you do the obvious thing. You fire him. And 16 years later, he died, ironically, of septicemia in an insane asylum. So the problem is that you can do the science, but it doesn't necessarily bring about change. Now, of course, in those days, there was no germ theory of disease, as was pointed out earlier. And indeed, there was virtually no statistics, so we now put confidence limits, and we can see it's all very significant. But of course, in those days, none of that was possible, so maybe we shouldn't be too harsh on his superiors. But his main sin seems to have been criticizing his superiors, who clearly felt they knew better than he did, and weren't going to be told what to do by a young upstart. So this is possibly a good lesson for all the young scientists in the audience. But the point is that the science doesn't necessarily need to the changes which it should bring about. So what I want to start by doing is giving you a very brief, very, very fast overview of the history of HIV/AIDS, and the story is really quite extraordinary. It must be one of the great triumphs of modern medicine and public health. I mean, in the 1980s, by the end of the virus, as you know, was discovered in the early 80s. By the end of the 80s, all of the basic epidemiology had been established. Much of it due to the work of Roy Anderson and colleagues, many of whom are in this room now. So within 10 years of the discovery of the virus, we knew the main routes of transmission, the doubling time, the survival, nice Weibull curves, shape pyramid of 2.25. We knew about the risk per sexual encounter, very low. Other STIs, enhanced transmission, R0 is about 7. By then, a diagnostic test for the infection had been developed, and the first antiretroviral drug was available. So the progress in AIDS science generally was just quite extraordinary and really unlike anything that's ever been experienced before. Within another 10 years, 3 drug therapy was available, although very expensive, $50,000 or thereabouts for a year's treatment. It was becoming clear that the main routes of transmission in developed countries were IDUs and MSM. In Asia, maybe IDUs and female sex workers, and in Africa, mainly heterosexual. So we understood how the infection was being transmitted. We also realized that for reasons which we still don't understand, The 9 worst affected countries in the whole world are all in southern Africa. And then countries like in the whole of North India, the prevalence of HIV is 200 times lower than it is in southern Africa, but they have poverty, they have sex work, they have migrant workers. So the question is, why is it that North India has so little AIDS compared to what we have? There's still some unanswered questions, but the drug development in particular is just quite amazing. I mean, within 20 years, you've got 3 drugs against a viral disease, when 20 years earlier, no drugs were available for any viral disease. In the 2000s, we learned more things. It was clear that the first thing is that the price of the drugs fell dramatically, and we can now buy a full course of antiretroviral therapy in South Africa for $100 a year, down from $10,000 or $20,000 a year. It also became clear that behavior change interventions don't work. SDI treatment doesn't work. Excuse me. Sorry, I should have turned this off. SDI treatment really doesn't work, but probably because not that many people have SDIs in the first place. CD4 was being used as a marker of progression. Viral load was being used as a marker of survival and infectiousness. You've fallen off the bottom of the slide, I think, but vertical transmission was beginning to be controlled. Triple therapy was stopping mothers from infecting their babies. So the progress through that decade was equally extraordinary. In the 2010s, in the first decade of this century, we discovered what does work. Male circumcision works, reduces transmission by 60%, but in one direction only. Pre-exposure prophylaxis, vaginal microbicides give about a 40% reduction, so not really what we want with an R0 of 5 or 6 or 7, but significant. Antiretroviral therapy can reduce and sustain the viral load from a level of 100,000 on average to about less than 10 per milliliter over a period of 5 to 10 years. And the drug costs are now very, very small. So the progress has really been really quite mind-blowingly fast. I mean, both in terms of the epidemiology, the understanding, the virology, and all the rest of it. But we can ask a series of questions. The first question we might like to ask ourselves is, what if we had listened to David Ho in 1995 when he said it is time to hit HIV early and hard? And he said this in the context of having just developed triple combination therapy, which in the case of most diseases would be a good reason to really roll it out and make it widely available. Well, for complex reasons where I still don't quite understand, apart from countries like Brazil where antiretroviral therapy was made widely available, most countries drag their heels. But we can use our models to see what would have happened if we'd listened. So this is data, this is the red dots of the antenatal clinic prevalence from South Africa. This is a very simple SI model fitted to those data, the red prevalence, incidence, mortality. The line on the top right of the graph is what would have happened if we'd started rolling out antiretroviral therapy in 1995 to the incidence. We could have stopped transmission by 2007 or 8. Of course, the prevalence the prevalence of those not on ART would have fallen dramatically, but of course, you would still have had a very large number of people on ART who would have to be kept alive for the rest of their natural lives, hopefully dying eventually of other or natural causes, and we would have reduced the mortality by orders of magnitude. And in fact, if we'd done it in 1995, we would have saved just in South Africa alone an estimated 1.8 million lives. But we chose not to do it, and we need to think carefully about the reasons why we chose not to do it. Okay, what about adolescence? We know that mother-to-child transmission by the turn of the century was getting pretty much under control, and certainly is now fairly well under control in most African countries. So children are kind of taken care of. Adults are another discussion. But what about adolescents? And the reason why I raise this is in the year 2000, these data were published showing the survival of children infected vertically from their mothers and the survival as a function of time after that. If a mother is HIV positive and doesn't get drugs, 30% of her children will be born HIV positive, and half of them will die by the age of 2. And if we take these data and we extrapolate them as we like to do, then they'd all be dead by the age of about 10. Now we notice there is, of course, one outlying point here which is a bit worrying, but if you do a very strict statistical test with multiple comparisons, maybe it's not significant. But so, this is what people thought was going on. Then in the early 2000s, Liz Corbett and Rashida Farand and others working in Zimbabwe made some really very alarming observations. They found they were running an AIDS clinic, they were running a general clinic in Harare, and they found that 2/3 of the adolescents who were coming to the clinic were HIV positive. They were all at an age where none of them had had sex yet. So the question is, how are they getting infected? This is 2 of the children. They are both 16 years old. They all had low CD4 counts. The median age in their cohort was about 11 years, and more than half of them were double orphans. Nearly all of them were at least single orphans. The child on the right has been in a wheelchair with arthritis since the age of 5. This tells me that all of these children are physically stunted. Their heads are a little bit too big for their bodies, and they're probably mentally stunted as well. So they've suffered enormous lack of development, both physical and mental. And even if you put them on antiretroviral therapy now, it's probably too late. But so the question is, what happened? Well, we already knew from the data from the Cascade study, we had this rather odd set of data in which they estimated survival as a function of age at infection for people from the age of 70 to people below the age of 5. And they're all nice Weibull curves, all with the same shape parameter of just over 2. But of course, what is most striking is the increase in the survival probability with age, and in particular the fact that if you're infected between the age of 0 and 5, you have your chances of your median survival is about 16 years. Now this is quite different from what we saw in the last slide, and of course all of these children in this study were hemophiliacs who were infected through blood transfusions. They were not infected vertically. But so if we just take the Cascade data and we tack it on to the end of the previous set of data, then we get a very odd survival curve, this biphasic survival curve, which looks like that. And the question is, why should it do that? What is it about the children, if you make it to the age of 3 or 4, you're then going to live for 16 years? And I think nobody's really answered that question, but it's a critical question which needs to be answered. And we can confirm that this really is about right, because we can take that model, essentially a statistical model, apply it to what we know about antenatal clinic prevalence, and we can predict the age distribution of HIV positive children in South Africa in the year 2007. So this is data from the Catholic Bishops' Conference, who are providing ART to adolescent children with HIV, and this is the prediction, and the blue line here is the prediction of the model. So it's pretty convincing that that really is what's going on. And we can also do something else. We can say, well, what would we expect the prevalence of HIV to be in adolescents in these 3 countries in the year 2003, and the blue line is a prediction of that very simple model, and the red dots are the points. So it does seem that this really is the case, that survival after being infected with HIV has this extraordinary biphasic distribution, and nobody really knows why that is, but maybe it would be important to find out. Okay, changing tack completely, I want to talk a little bit about treatment guidelines. Chris Dye said in his lecture that modeling is not yet on the radar of public health, or at least on the grade system for evaluating public health interventions. And so I want to think a little bit about why that is the case. Now, in the first significant guidelines for when to start treatment were from the International AIDS Society and the Department of Health and Human Services in the United States. And what they did was, very sensibly, they took data from the MAX cohort, this cohort of men infected with HIV in the United States, and this is all before antiretroviral therapy was available, and they plotted, this is their data, they plotted the probability of developing an AIDS-defining illness in the next 3 years as a function of viral load and CD4 count. And of course, if you have a high viral load, you've got a high probability of developing an AIDS-defining illness. If you have a low CD4 count, you have a high probability, and high and low and high is the other way around. So they could use this to work out what is the predictive value of CD4 counts and viral loads for deciding whether or not you're likely to have an AIDS-defining illness in the next 3 years. So to make life a little bit easier, I've replotted those data on an area plot. So this is exactly the same data. So everybody lying along this combination of CD4 and viral load has a 5, 10, 20, or 40% chance of developing an AIDS-defining illness in the next 3 years. And the brown dots on this slide are data which Bertrand Auvert collected from young men in Orange Farm in the year 2000. So these are the CD4 counts and the viral loads from a random sample of young men in a township just outside Soweto. So in 2000, the Department of Health and Human Services decided that what we should do is we should start everybody on ART if they have a viral load above 10,000 or a CD4 cell count below 500. So everybody in this part of the graph, all of these little brown dots, should be started on ART immediately. And that was based on this analysis of the max cohort and the probability of progressing to an AIDS-defining illness within 3 years. The International AIDS Society came up with a very similar set of recommendations, and they said that everybody to the right of and below the line should start ART immediately. Between the lines, you should consider starting ART, and these few guys over here don't need to worry about ART, at least not yet. Now, for both of these sets of data, 90% of the young men in this particular setting in South Africa would have been eligible for immediate treatment with antiretroviral therapy. 2 years later, the World Health Organization came out with their guidelines, the first time they produced guidelines on where to start treatment, and they decided that we should set the bar at 200. And what this meant was that only these people should be started immediately on ART, and all of these people should wait. So a massive change, a really, really important change in the guidelines which had profound consequences. So looking at all of this, I thought, well, there must be some good scientific reason why they've changed from 350 or from 500 to 200 and dropped the viral load criterion. So I read the guidelines very carefully, and the only thing they say in the guidelines to justify this really quite dramatic change was that you should only start treatment in asymptomatic patients when the count drops below 200. They say that while beginning therapy before 200 clearly provides clinical benefits, but the actual point above 200 at which to start therapy has not been determined. And there is no discussion of costs, side effects, drug resistance, compliance, or anything else, all of which may have been used to argue that starting later is a better thing to do than starting early. So the World Health Organization seems to have failed completely to take into account any of the science which had been done and which was known about what HIV does to you at the time they made this decision. The consequences really were quite profound, because the International AIDS Society and the DHHS then revised their guidelines downwards to 350, not to 200, and it took another 10 years before finally we're back to 500 again. So we are now back to where we were in the year 2000, with the IAS and the DHHS both saying all adults should be offered ART regardless of CD4 cell count, based on data showing that all patients may benefit from ART, and it reduces the likelihood of HIV transmission, provides clinical benefit. So I think there was an enormous failure of the science there to inform policy, and the reasons are clearly complex and involve lots of players and different people. But it comes back to this question that we can do the science, but it doesn't help if we do the science if it doesn't inform the policy. Okay, the last sort of example I want to give, and this is really just sort of a scattering of different examples, but I think all with the same idea in mind, which is that how do we make sure that the work we do, which I believe is really important and without which we will never make progress, how do we ensure that it really affects and influences policy? Clearly it's not the only thing to determine policy, but it's an important thing. So I've been doing some work with a very interesting man called Messiah Kato, who's a Japanese guy working at the World Health Organization office in Vietnam, looking at the epidemic in Vietnam. And then essentially what they tell me is that the epidemic in Vietnam works more or less as follows. We have intravenous drug users, female sex workers, male clients of female sex workers, low-risk women is a sort of catch-all phrase to capture the partners of all of the men in these various groups. We have some men who are also MSM, who are also IV drug users, and some female sex workers who are also IV drug users. And part of the motivation for them wanting us to do this job is that the government it's clear that IDUs are an important driver of the epidemic in Vietnam. And what they would like to do is persuade the government of Vietnam that they should stop putting IDUs in detention centers, which is what the government likes to do, and instead strengthen their methadone maintenance programs and combine the methadone maintenance programs with antiretroviral treatment. This would be cost saving for both programs and should have a profound effect on the epidemic. So behind this is this desire to try and persuade the Vietnamese government to make a radical change in their policy. They also tell me that a critical point of this is that the reason why a lot of women there are a lot of women in this group here, is that a lot of women they're actually drug users primarily, but they do sex work to raise money to buy their drugs. So this is what really determines the women in this group. And they have estimates of the number of people in each of these groups and the number of people in each of these subgroups. And they also have really, bad by your standards, but good by public health standards, data on prevalence trends of HIV this is one province in Vietnam called Can Tho, which is sort of halfway between Ho Chi Minh City and Hanoi. But so it's not great. I mean, there are big error bars, but it's there. And so what I did was to simply fit the usual sort of SI model, etc., to these data with assumptions about the size of each group, the number of people in each group. Now we have data for example, all the female sex workers. We don't have direct data on the prevalence of HIV in the women who do and do not use drugs, but we put that into the model. So in the model we have these subgroups of women who use drugs and MSM who use drugs. And you fit an SI model to that, and it really doesn't look too bad given the large error bars, but there's a curious thing, which is that the prevalence in intravenous drug users sort of goes up remarkably quickly. And I said to them, listen, I simply don't believe this. I don't believe that HIV goes up that fast anywhere in the world, so this can't be right. So I shall just ignore these points over here. So when I did the fitting, I ignored these points here and just sort of fitted to those points, and it still looks pretty good. However, having done that, we thought about it for quite a long time, and I thought, well, maybe the model's wrong and they are right. So I thought, well, given that the sex workers are quite important in this, what happens if we change the model slightly? Just give it a little tweak. And all we did was to force the model to work in such a way that the infection had to come through the female sex workers before it got to the IDU. So it couldn't get into the IDU population, excepting from the female sex workers. And if you do that, then you get a really very nice fit. So what the model seems to be trying to tell us, given all of the uncertainties, is that the epidemic in Can Tho province must have come in through the female sex workers. Then that delays the start of the epidemic in intravenous drug users. You've then got a very high force of infection in intravenous drug users, and it goes up very quickly. So I think, that's quite interesting. Of course, I suppose it means that when we eliminate the epidemic, then controlling it in female sex workers is not going to be enough, because the epidemic here drove the epidemic there, but now that it's there, it no longer needs this epidemic to drive that epidemic. But so at least the model can help us to think about what's going on. But of course the error bars are very big, but it tells us other interesting things. So, for example, we see that the prevalence in IDUs is about 40%, MSM 10%, female sex workers 5%, clients 1%, and low-risk women extremely low. And then the question is, if we're going to use treatment for prevention, how do we do that? And clearly it's very easy to find people in this group because half of them are infected. But if you want to find women in this group, you're going to have to test 1,000 women to find 4 with HIV, and the testing costs are then going to outweigh the treatment costs. So it raises those interesting questions of that kind. And indeed, if we look at the prevalence in each of these risk groups, it goes almost to 0 in the low-risk women, but the number of people living with HIV is actually as high in these women as those women. So it raises interesting and important questions about the logistics of control. But we can go a little bit further, and we can do the usual kind of R-naught calculations, next generation matrices and things, but we can try and break it down, and I'm not sure whether breaking it down in this way is useful or not, and so this is discussions we've been having. But we get an overall R-naught of 10 for the whole thing. We see that if we were to stop HIV in the female sex workers, also IDUs, then we'd have this kind of sub-epidemic here, which appears to have an R-naught value of about 1.2, because the female sex workers infect a lot of clients, but the clients don't infect very many sex workers. So maybe we could split the epidemic in half by dividing it there. It's clear that the IDU circulation is really what's driving the whole thing. So we can then, if you want to we can extend this a bit further, and we can sort of put various interventions into the model. So we've got, this is the current coverage of ART, what the effect on the incidence of HIV will be. This is what would happen if we extended the coverage to get 90% of those below 350. If we add in methadone maintenance for IDUs and condom programs for MSM, we bring it down a bit further. If we do annual testing with immediate treatment, we can eliminate HIV. So we can begin to explore various ways of controlling the epidemic. So that's really about it. But really, all I wanted to say was that it's very clear that the understanding that mathematical models bring is absolutely essential for good public health. The difficulty is that both people and politicians make decisions for many reasons, most of which we don't understand and which they may not even be aware of. So, at least in the third world, I mean, I think the situation is better here. The interaction between the theory and experiment and the data and the national veterinary and public health services is much closer. We have to think very carefully about how it is that we're going to persuade people of the value of our work, how to persuade them to take action on the basis of our work, and most importantly, maybe understand what it is that constrains their world and their decisions. So thank you.
Thanks, Brian. Questions, comments, Tyler?
Yeah, very nice talk. I'm wondering, you were saying about the mystery of why you have so much transmission in southern Africa compared to, say, northern India. And we published something recently about the presence of cofactors such as malaria, especially malaria and other infectious diseases that seem to raise viral load and augment transmission in Africa, southern Africa, but not, say, in northern India. And I'm wondering if you think that's a good hypothesis, and that you would need to treat these co-infections as well, and try to deal with them jointly with HIV to get the kind of reduction that we'd like to see in southern Africa.
Look, I mean, so we don't really have malaria except on the fringes in South Africa, but we do have extraordinary rates of TB. I mean, HIV positive
would be another co-infection. It's important.
I mean, HIV positive mine workers with silicosis have a TB incidence of 16,000 per 100,000 per year, which is quite 16% a year, which is quite mind-blowing.
Yeah.
So it may be. I don't know the answer. Maybe other people who do know the answer, but Martina.
I think when you start to ask those questions, though, then you need to move beyond South Africa and think about Botswana, that has a pretty good healthcare system and the highest per capita income, I think, in southern Africa, and the highest rate of HIV. So I don't know about the cofactor argument working in that context.
Yeah, I'm not sure. I mean, just a side observation. If you look at the effect of TB of HIV on TB in Zimbabwe and Botswana, the incident rate ratio in Botswana is about 10, and in Zimbabwe is about 40.
Yeah.
So the impact of HIV on TB in Zimbabwe is 5 times greater than it is in Botswana. I think interesting, but I don't know the answer.
Jim, last question.
So one of the issues about relating to public health officials is that we need to get our models in terms that they can understand, but we need to be sure that the inferences that we make from our models are robust to realistic relaxation of the simplifying assumptions in those models. And a strategy that can help that with both that we're using in Michigan with the health officials is to narrow down to specific policy implementation decisions, and then adjusting our models, doing inference robustness assessment to make sure that the inferences we make are robust. So I think that a lot of issues, that the simple models will not hold up to that standard. You've got to relate models to as much data as possible, and we know increasingly amount about the transmission at different phases after infection. We know that episodic risk behavior is a huge determinant and driver, and we know that pairing and partnering have big influences. And so we need to relax those assumptions in our model in the context of answering specific questions that we can relate to the public health.
No, I mean, I think that's right. I mean, I think what you're saying is we need to engage the public health officials, politicians, whoever they are, at a much earlier stage, and then try and find a way to work with them so they feel engaged in our process, and at the same time make sure that we at least agree amongst ourselves about what is important in these processes. That's right. It's still difficult to do.
I see there are one or two others that want to ask, but we'll have to postpone that. Thanks again, Brian, for a terrific presentation.